So as indicated, I'm going to be speaking about laser ablation or LIT in primary and secondary tumors. This is my relevant disclosure. So the basic premise of LIT is that heat kills cells if given for a long enough period of time. And the relationship between temperature and time is defined by something called the Arrhenius equation. Now, if you can accurately measure the temperature to which something is heated, and know for how long it's being heated, then you can make predictions as to the extent of damage that is created. And so the system that we use, which is the NeuroBlade system, produces these three thermal damage threshold lines, TDT lines. And the blue line is more or less reliably ablated. So everything inside it is heated to the equivalent of 43 degrees Celsius for 10 minutes. The yellow line predicts tissue that is safe, so everything outside of it either recovers or is not damaged in the first place, and that's the equivalent of 43 degrees Celsius for 2 minutes. The white line we don't actually use in clinical practice. It is also obviously reliably ablated, but it's by a different mechanism, but it's 43 degrees Celsius at 60 minutes. But MR thermography is really what makes this happen. LIT's not a new concept. It goes back into the 90s, both in Boston and Germany, but they had no way to really measure what was going on. So until MR thermography came into being, that really laser ablation really had nowhere to go. And today there are two FDA cleared laser systems, each with their benefits and downsides. Both of them operate in the near infrared that heat up tissue. And the system that we use not only has a spherical output, but also a side fire approach with different laser probes. And the motion of the laser in and out and rotation is done robotically from the MR control room. So we got into this back about almost 2 decades ago with the first in human study, which was a thermal dose escalation trial, where we first treated recurrent glioblastoma tumors to the yellow TDT line. And if there was acceptable toxicity, we would move on to the blue and then move on to the white. And this occurred from 2008 to 2009, less than a year. 11 patients were enrolled. We did this at Cleveland Clinic, as well as our friends down the street at University Hospital, Cleveland Medical Center. Ultimately, 10 patients were treated. All treated patients had treatment necrosis. The lesion was more or less between the blue and white line, and with further analysis, it really was at the blue line. Median survival was over 300 days, indicating this was a highly selected patient population, and of course, all died to disease due to disease progression. So there were 2 steroid reversible toxicities that led to neurological deficits, one of the dysphagia and the visual field cut. And there was one patient who had an immediate hemiplegia. Now, at our center, we routinely did diffuse intensive imaging to map out the corticospinal tract. That was not a requirement of the study, and it was not being done at the other center. And that's where the patient had a hemiplegia. And in retrospect, indeed, there was an injury to the corticospinal tract, thermal injury. One patient developed neutropenia, 2 others developed DVTs. Now, we only really looked at complications in the first 2 weeks. There were 2 complications that occurred after that. One had a delayed hemorrhage due to a pseudoaneurysm on a distal branch of the MCA, and we don't know whether that was thermal or whether that was due to the biopsy that was part of the study. We've really not seen that since then. There was one patient that developed seeding along the biopsy tract. We have seen that since then, and we now have the practice of going from superficial to deep, as opposed to doing deep to superficial. By going superficial to deep, we don't drag tumor cells back up the laser tract. This is a pre and post 24-hour imaging of a recurrent glioblastoma in the corpus callosum. The orange lines represent the predicted area of ablation. At that time, we were limited in terms of the axis that we could do. So we had to actually come up more or less straight down on this. Now we would go along the long axis of this. But you can see that in the 24-hour post-procedural scan that the area of predicted ablation very nicely matches the area that was indeed ablated. This is the Kaplan-Meier curve, again, showing the 316-day survival, and this was published back in 2013, 10 years ago. So what we learned from the first human trial is that, first off, lit and brain tumors in humans is feasible, that the TDT lines are indeed predictive of ablation, that the extent of ablation is best observed at 24 to 48 hour post-ablation MRI scans using T1 contrast enhancement. Some neurological toxicities can be reversed with steroids, and that ablation stops at heat sinks, such as ventricles, sulci, and large vessels. And also that DTI tracking is important. And today, the software system allows us to actually incorporate DTI tracking in our management of the actual laser ablation. As you can see, the white areas represent, in this particular case, corticospinal tract, and we can tailor our ablation to try and keep the blue line from going into those areas. My colleague, Ali Mohammadi, looked at this because we did have some patients who had deficits, even though we were doing DTI, that we, at the early cohort of patients, we could not superimpose those on the actual treatment monitoring software. And he determined that indeed that overlap of the blue line with the corticospinal tract significantly predicted neurologic deficit. So after the first in human stand, we extended our application of this to newly diagnosed tumors. And this was a man in his 40s who had a seizure in the shower and had this ring enhancing mass in the cingulum immediately below the paracentral lobule. And I think most of us would admit that that's a difficult area to access. Perhaps not with parafascicular surgery, but at least in my hands, it would be difficult. So we did a stereotactic biopsy, and at the same time did a laser ablation of this. It turned out to be MGMT methylated IDH1 wild type GBM. Scan on the right is the 24-hour post-scan. That hemorrhagic and proteinaceous deposits in the tumor. That's not enhancement. And this is his scan over 70 months, which shows he went out, obviously he underwent stoop afterwards, but he had no evidence of residual or recurrent tumor in those 70 months. But as you also know, GBM is not really a focal disease, and he then had a remote recurrence of his tumor in the left frontal lobe down near his speech area that did not lend itself to laser ablation. He ultimately succumbed to that lesion, again, never having a recurrence at the primary site. And then we moved on to other areas such as butterfly gliomas. This is a patient who had a multifocal GBM, one that was removed in the left parietal area, and then again, this area in the anterior corpus callosum and left frontal lobe. He had chemoradiation for both lesions. The lesion on the left, however, progressed despite chemoradiation. The lesion, which you can get a hint of on the scan on the right, in the left parietal area, remained stable. And so we then went in and did a laser ablation using two trajectories of this, showing the feasibility of doing that. This was a cystic glioblastoma in the right parietal lobe. I initially had turned this down thinking that the cyst would act like a heat sink, but Eric Luthart from St. Louis told me, oh, he does these things all the time, and they don't act like a heat sink because the heat it actually is confined within the cyst. So I treated him, and there he is at 9 months. He ultimately did recur at a year and ultimately succumbed to this. So what we learned after the immediate first-in-human study was that it was possible to get durable control of newly diagnosed glioblastomas when they were followed by stoop therapy. That butterfly glioma ablation was feasible, thalamic tumor ablation was feasible, and cystic tumor ablation was feasible. And one difference between open surgery and lit is that there is no brain shift, because basically the lit catheter puts the finger in the dike and there is no CSF leak. So this study, which was a multi-center study, looked at using lit in difficult to access high-grade gliomas. 34 patients, 24 of which had GBM. Median age was around 56. Most of them were male, and these were all supratentorial. 16 of these were newly diagnosed. For those that were recurrent, the median time from initial diagnosis was about 30 months. Tumor volumes ranged widely from about 1 to 50 cc's. And there were 5 temporary deficits, 2 sustained deficits, 2 patients got an infection, and the 1 each miscellaneous things. There was 1 patient who died. In this particular study, median survival was not reached. Estimated 1-year survival was 90%, and estimated progression-free survival was 5 months. But one of the big take-home points of this, or 2 of the big take-home points, is that there were 2 favorable prognostic factors. One was the extent of ablation, and the other was small volume. They probably go hand in hand. But you can see here that if you had favorable coverage, that you had a much better progression-free survival. In fact, it was statistically significant than if you didn't have favorable coverage of these tumors, almost twice as long in terms of progression-free survival. This is a patient who actually had a multifocal GBM who kind of acted as his own internal control. We had some technical difficulties, and we were really only able to ablate the anterior lesion, and that's the 24-hour scan. He then underwent, he chose not to have another laser ablation and underwent Stoop therapy. And here he is at 3 months. You can see that the anterior lesion has a thin eggshell of enhancement characteristic of a post-lit procedure, whereas the posterior lesion has substantially grown and has a rind of enhancement. And on cerebral blood volume, MR, the posterior lesion lights up, whereas the anterior lesion is cold. And ultimately, he succumbed to the growth of the posterior lesion that was not treated with lit, while the anterior lesion continued to regress. So what we learned from this cancer medicine paper was that the extent of ablation appears to be important. And actually, if you look at extent of ablation versus extent of resection, the results are comparable in both upfront and recurrent glioblastoma. And it maybe size may matter. And I think the reason size matters is because it's much more difficult to get a complete ablation for a larger lesion. So this is another multi-center study, Cleveland Clinic, WashU, in St. Louis, Yale, and Duke universities. And in this particular study, 2 of the institutions were using lit to treat biopsy-proven glioblastoma, and the other 2 institutions were not. And this was during a contemporary period of time. So this was a propensity-matched group of patients. And the endpoints we looked at were overall survival, progression-free survival, disease-specific overall survival, and disease-specific progression-free survival. And once again, we graded these things as whether they had favorable characteristics in terms of extent of ablation. And you can see that there was a wide range of outcomes in terms of extent of ablation in this group. The take-home point was that in those that had favorable ablation, both disease-specific overall survival and disease-specific progression-free survival were significantly better than the propensity-matched controls who just had biopsy and conventional Stoop therapy. And this is level 2B evidence for the fact that laser ablation in this group of patients actually is of benefit compared to biopsy alone. So coverage is, again, an independent predictor of all outcomes except maybe overall survival, and it's a safe, effective treatment compared to biopsy and Stoop alone. All right, secondary tumors. So we're all familiar with radio-resistant tumors in terms of fractionated radiotherapy, renal cell melanoma, and so on. There is some literature to suggest that there may be some radiosurgery resistant histologies as well, triple-negative breast, colon, and BRAF wild-type melanoma. But there is a prospective study that was done several years ago led by Veronica Chang. That was a multi-center study, and it was called the LASER trial. And the upshot of this was looking at patients who had failed radiosurgery for their brain metastases, and all different types of tumors were open to the study. And the concept was to do needle biopsy of these to define whether or not they were radiation necrosis versus recurrent tumor. What this basically showed was that if you had a complete ablation of radiation necrosis, there was no recurrence. If you had a complete ablation of recurrent tumor, 30% of the tumors recurred despite the ablation. So Clark Chen, I think, pioneered the approach that we're using now, which is to do fractionated radiotherapy, or radiosurgery rather, after doing LIT for the biopsy-proven group. So when do you use LIT for brain metastases? Well, I think it's clearly an option when there's a radiosurgery failure, either recurrent tumor or radiation necrosis. I think that the jury's still out on whether there's any real role for it as an upfront treatment for radiosurgery resistant histologies. And larger lesions are less likely to respond to stereotactic radiosurgery when used as a single treatment. At our institution, we use staged radiosurgery with another treatment at a month and had really excellent results in terms of tumor control for brain metastases that are more than 2 centimeters in size. That is more or less comparable to the control rate that you get for tumors that are treated in a single session that are less than 2 centimeters in size. And this is what I alluded to here. We're using stereotactic radiosurgery after LIT. It produces much better control than LIT by itself for recurrent tumors. So what do these studies mean for your patient population? Well, biopsy at the time of LIT allows you to have an accurate diagnosis of whether this is tumor or radiation necrosis, and then therefore whether or not you need to do adjuvant radiosurgery after LIT. Also, these studies also showed that time to steroid independence was much faster in the group that had LIT in these diagnoses. Well, what else can you use this for? We saw low frequency and ultrasound can open up the blood-brain barrier. Well, LIT does as well, although it's much longer than you get from ultrasound. And Eric Luthart has been looking at using this approach to enhance drug delivery for those that don't typically cross the blood-brain barrier. When tumors are very large, it can be dangerous to use LIT alone. And this is a report from our institution looking at the combination of LIT to kill the tumor and then parafascicular surgery to debulk it. This is an example of radiation necrosis. Probably took several trajectories to do this, probably took a fair amount of time. And then immediately thereafter, going in with brain path and debulking this. A word of caution, you can't wait till the next morning to do this. I had a patient go brain dead during my debulking with brain path the next morning. And, high urine output, no recovery, the ICP was just too high. Perhaps even the addition of the brain path device was enough to push her over. But clearly, if you're going to take this approach, you need to do it right then and there. So here's a series of about 240 patients from our institution. And the upshot here is that it's a safe, effective treatment. Also, over time, the time it takes to actually do the procedures has come down with the learning curve, and that we have better laser efficiency and coverage as the learning curve gets better. And you can see that the time of the procedure has progressively declined over time. And, laser ablation has come of age in terms of those who do guidelines. So NCCN now has indications for LIT, as well as the Joint CNS-AANS Society's position statement on LIT. And we expect that these will get get longer as time goes on. So to sum up, the next generation of LIT is here compared to what was going on back in the 90s. And it's gone from a vision to an investigative device to now an essential neurosurgical instrument, in my opinion. It offers a surgical option for some, and perhaps that otherwise wouldn't have a surgical option, and perhaps it may be better than open surgery for some others. There is, as with any new technology, a learning curve. I think we're well along the way, and there's better ease of use with the newer devices. Again, size matters. Again, if you have a large lesions, please debulk it immediately after the ablation. And the laser ablation, in my opinion, has come of age. So when I trained many, many years ago, the dogma was the only good craniotomy was a large craniotomy. I spent a lot of my career trying to make a small craniotomy the gold standard. I think with the era of laser ablation, the future may look like this. So on behalf of our team at the Rosella Burkhardt Brain Tumor and Neuro-Oncology Center at the Cleveland Clinic, I thank you for your attention.
Thank you for a great talk, obviously, and for your work. This is more just a technical question. We're just starting our LIT program, and the only problem we've had is a young lady who had about a 3-centimeter GBM motor strip, didn't feel like I could take it out. It took a fairly long time to heat the tumor up, and had some malignant swelling afterwards. And ultimately I had to do hemicraniectomy on her. She's since done very well. However, is there anything that you've found, any factors to predict malignant edema other than maybe size or time to heat?
And I think it's size. And, typically we don't do, we'll only go up to about 2.5 centimeters without considering debulking. Also, you're in, a high price real estate area there. If you did that at the right frontal pole, probably nothing would happen symptomatically. But, being right in the motor strip, that it doesn't take much for things to go south.
Thank you.
And also, I always put people on a fairly high dose of steroids immediately afterwards and do a very slow taper. I think that's another point that needs to be made. Yeah.
Great talk. My question is in terms of the tumors in the posterior fossa. How do you predict similar along the lines of already mentioned in terms of the edema and use of LIT, primarily in the periventricular zone versus hemispheric? How do you, with your experience, try to tackle those cases?
Yeah, well, again, you have to pick and choose in terms of size, and high dose steroids immediately afterwards. And they get a blast of steroids before we even start. And I think steroids are your friend. Some people think that LIT may cause an immunologic response as well, that helps keep the tumor under control. I personally don't. And certainly if you're going to use a lot of steroids, that's not going to happen.
So Gene, quick question about, so basically usually for new GBMs like de novo that are inoperable, not maximally resectable, so you're not doing upfront LIT followed by RT-TMZ, only if it's on protocol?
No.
Or case by case basis you are doing?
It's case by case. And again, the guy I showed with the singular gyrus one was a perfect case for this. I've got other ones that have long-term local control, but have failed remotely and not along the biopsy track or laser track. I mean, again, I think there were studies back in the prior 50, 60. Pat Kelly showed that you've got tumor cells in the other hemisphere if you actually go to biopsy them. And I think that's really the case.
So Gina, is there any data with recurrent, just shifting gears, recurrent GBM LIT followed by maybe fractionated SRS? And there's like an NRG protocol, I think is BRG, BN010, which is looking at fractionated SRS with immunotherapy. Any data with LIT, with FSRS, and maybe immunotherapy?
Not that I'm aware of.
I'm sorry, I was asking about the same thing with the posterior fossa tumors. Is there any particular size that you utilize the same for supratentorial and infratentorial, or something else that you consider?
Yeah, well, I think first off, you need to assess how much of a pre-existing edema there is, how much fourth ventricular compression there is.
Right.
You know, if, and what its proximity to the fourth ventricle is. You know, you can have a perfect storm where you've got lots of edema. It's a big tumor and it's right next to the fourth ventricle. Probably not a great idea to use lit in that circumstance, or unless you're going to do an immediate debulking. On the other hand, you could have a small tumor that's remote from the fourth ventricle with almost no edema, and that would be a great candidate for lit.
Thank you.
Do you have any experience in using this in Lee-Fraumeni patients?
No,
Okay. I've treated a kid once and I'm going to go back for 2 more lesions with lit.
yeah,
Okay.
how to work.
Worked great on, well, he has 2 brain path resected lesions, a lit one in the descending cortical spinal tracts, which has been stable for 2.5 years. And so I was going to target his next 2 that are growing with lit based on the teenager's preference, but also mine.
Sounds great. Anecdotally, by the way, it's also a great treatment for cavernous malformations that are hard to access. Counterintuitively.